So hello and welcome to episode 16 of the Surgical Discussions podcasts with Johnny and Ed. My name's Ed.
And my name's Johnny.
And today we're going to be talking about the pancreas. Specifically, we're going to talk about the important anatomy of the pancreas, its structure and its function. We're then going to talk about two important sets of conditions. These are pancreatitis and pancreatic cancer. So talk us through the anatomy of the pancreas, Johnny.
So, the pancreas is a retroperitoneal organ lying at level 2 in the transpyloric plane.
Level L2, not level 2.
Yes, sorry about that. It's in three parts: the head, the body and the tail. The head has the Untitled process.
What's that?
That is a part which lies posterior and is due to the embryonic development. It develops in two separate parts and then it fuses together.
Okay. That's a remnant.
Yeah.
Okay.
So the relations, it's within the C curve of the duodenum. Posteriorly lies the inferior vena cava, the aorta, the diaphragmatic crura, and the mesenteric vessels. Anteriorly lies part of the stomach, and laterally, as you can see in the diagram, lies the splenic hilum. The blood supply to the pancreas is fairly simple. The arterial supply is via the superior pancreatoduodenal and the inferior pancreatoduodenal arteries and the splenic artery, and the venous supply is corresponding to that of the arterial supply.
Okay, and what about the lymphatics?
The lymphatics, it drains to nodes on the upper border of the pancreas and also to the superior mesenteric nodes.
Okay, so that's some basic anatomy. What about the functions and structure?
Well, as everyone pretty much knows, it's divided into the endocrine functions, which are production of insulin, glucagon and somatostatin, and the exocrine functions, producing proteases like trypsinogen and lipase, so chymotrypsinogen. And these are both proenzymes, which later are activated to the enzymatic form.
Yeah, and that's important because if they weren't, then they'd probably just digest the substance of the pancreas, wouldn't they?
Yes.
Yeah.
Okay, so it's made up of an acinar structure, much like the breast. So it's got alveoli, which then drain into ductules and then into the ductal system. So the two main systems, there's the main system, also known as the Warsung, which is joined by the common bile duct and drains into the ampulla of Vater, which we discussed earlier in the gallstones.
Yeah, and then the ampulla of Vater then goes into the into D2 of the second part of the duodenum.
Yeah, and there's also the accessory duct, which drains superiorly to the main duct.
Yeah, and that accessory duct is also known as the duct of Santorini.
I like the accent.
Thanks.
Sounded great.
So I'm going to talk a little bit now about acute pancreatitis, which is a very important cause of an acute abdomen. So it can basically be defined as an inflammatory condition of the pancreas. In terms of the epidemiology, it's fairly common, tends to affect middle-aged people, has an equal sex preponderance, and has quite a high mortality at about 12%. In terms of etiology, the causes can be remembered using the mnemonic get smashed. And appropriately, the first two letters of this, the G and the E, show the most common causes. So G is for gallstones, which makes up about 45% of cases of acute pancreatitis, and E for ethanol, about 25%. And T is for trauma. The smashed part of the mnemonic, S is for steroids, M is for mumps and other infections such as Coxsackie B, A is for autoimmune, for example, polyarteritis nodosum, S is for the famous scorpion venom, usually that of the Trinidadian scorpion.
But there are others as well.
There are two others, I think.
Yeah.
But the Trinidadian is probably the most important. Actually, this whole scorpion thing is pretty pointless, really.
Yeah.
It's in the mnemonic, so there we go. H is for hyperlipidemia, but importantly, there are other H's, such as hypercalcemia and hypotension. E is for ERCP, or endoscopic retrograde cholangiopancreatography, and D is for drugs. An important drug to remember would be thiazide diuretics. Finally, 20% of these can be idiopathic, and in fact, this is the third most common cause of acute pancreatitis. Yeah. For this reason, some people use the mnemonic GATE smashed, because then you have gallstones, alcohol, idiopathic, then T for trauma.
I like that.
Yeah, GATE smashed, but it doesn't really sound as good. So in terms of the clinical features, as always, we divide it up into signs and symptoms. Important symptoms would be a patient presenting with epigastric pain that radiates to the back and is relieved by sitting forward. And this pain may well be associated with vomiting.
Which tends to be intermittent and bilious in nature.
Okay. In terms of the signs, these can be general or specific. In terms of general signs, patient will be unwell, with a fever, possibly a tachycardia or tachypnea, and they may well also be jaundiced. In terms of specific, they may have signs of local or general peritonitis, together with shock and a paralytic ileus. There are some specific signs that are associated with pancreatitis. These are Cullen's sign, which is peri-umbilical ecchymoses, and Gray-Turner's sign, which is flank ecchymoses. Okay, so moving on to investigations. Johnny, why don't you tell us a little bit about these?
I will.
Please do.
Okay. So in the normal method of going through the investigation so that you don't forget anything, we'll start with cultures, and in this obviously we do the urine dipstick, which may find bilirubin due to the jaundice, or glucose due to deranged endocrine function.
Yep.
Blood tests, arterial for an ABG if they're particularly unwell. Venous bloods, an FBC, which may show a leukocytosis or a low hematocrit, and a CRP indicating inflammation. Use and ease for general unwellness and dehydration, and perhaps renal dysfunction.
Yep.
LFTs, as we mentioned, may cause jaundice, so you need to measure these. Importantly, amylase, lipids, as these are causative. Serum lipase, which we'll discuss a bit later. The calcium, once again, causative, hypocalcemia.
Which can also be resultant as well. Severe pancreatitis can cause a hypocalcemia.
A hypo, yes,
Yeah.
but a hyper causes it.
Oh, yes, okay. So hyper is causative, hypo is resultant.
Yeah.
Good. Thanks for clearing that up for me, Johnny.
Okay. And also glucose and albumin.
Yeah. What about imaging?
Imaging, well, we need to do x-rays. So you can do an erect chest x-ray to check for any perforation. You can also do an abdominal x-ray looking for a sentinel paralytic ileus.
Okay, and that represents an ileus of the duodenum, doesn't it? Yeah. And also in some x-rays, especially if the patient, say, has acute on chronic pancreatitis, you may see a degree of calcification as well within the pancreas.
Yeah, I think that's mentioned in the chronic pancreatitis.
No,
part.
but just like to give people a complete idea of the things.
Okay. So next imaging modality is an ultrasound. Here you're looking for signs of inflammation and edema around the pancreas, or perhaps a pseudocyst, which is a complication of acute pancreatitis. And then you've got CT imaging, which is the best imaging for acute pancreatitis. And this defines the anatomy and the ducts and looks for any dilatation or problems.
And it's also helpful with prognosis as well. There's a scoring system, isn't there, for CTs?
Yeah. The Balthazar scoring system.
Oh, great.
Yeah. General knowledge.
Good stuff.
And finally, you can do an ERCP for gallstones. But remember, this is also a cause of acute pancreatitis.
Yep.
So amylase, this is traditionally the test for pancreatitis. And it's found raised in about 80% of pancreatitis cases within a couple of hours, 2 to 12 hours. And it tends to return back to the normal in about a week. However, it's got poor specificity, but you've got to remember that in a lot of hospitals they set different levels But in the books it says that it's more likely to be pancreatitis than other causes if the level is greater than 1,000.
Yeah, that's with the traditional test. But some, as you say, some hospitals have different things, don't they? So you need to check the hospital range first. Yeah.
And it's important to remember that a higher level of amylase does not indicate the severity of the pancreatitis.
Okay.
And then there's the newer test, which is probably the best blood test, which is the lipase, the serum lipase. And this is better as it's a more specific test for pancreatitis.
Yeah.
So here we can see an abdominal CT scan, and the arrow points to the acute pancreatitis, showing the inflammation around it.
Yeah, and CT is the best test.
Best test. Best imaging test.
Yeah.
The prognosis of acute pancreatitis can be measured to a certain amount via a number of different scales. There's the Glasgow, the Imrie, or the Ranson scale. I'm sure there are others, but these are the ones that we've heard about. These scales go to predict the severity of the disease and therefore the mortality. The Glasgow is more traditionally used in the UK. However, the Ranson scale can be used for alcohol-induced pancreatitis. Okay, so the Glasgow scale, nicely, it uses the mnemonic pancreas. So the factors that you're looking for are a low PaO2, less than 8, an age of greater than 55, a neutrophilia of greater than 15, a low calcium of less than 2, an impairment of the renal function, so a urea of greater than 16. Then you're looking for enzymes, so a raised LDH and a raised AST, a low albumin, and a sugar of greater than 10 millimoles.
Yeah.
The severity is graded if they have one of these factors, it's mild, 2, it's moderate, and if they have 3 or more of these criteria, within 48 hours, it's severe pancreatitis.
Yeah. Okay, management. So as always, management can be conservative, medical, or surgical. In terms of conservative management, you need to keep the patient nil by mouth. You give them an NG tube. You obviously want to give them fluids, analgesia, particularly opioids.
Especially pethidine.
Pethidine, yep, that's the one we use for pancreas pain, isn't it? Yeah.
Because then it doesn't cause a spasm of the sphincter body.
Yeah. You want to correct any abnormal metabolites. So, for example, if there's a hypercalcemia or a hypocalcemia, even. You want to give oxygen to try and keep that PaO2 above 8. You want to give insulin, possibly on a sliding scale, as this can help, obviously, to control the glucose. And you want to finally think about alcoholic complications. If your patient's pancreatitis is caused by alcohol, and they suddenly, within the hospital environment, they may develop withdrawal. So you need to think about perhaps giving them chlordiazepoxide as a regime for that. In terms of medical management, antibiotics should be given for moderate or severe pancreatitis. So that means pancreatitis with a Glasgow score greater than 2. And the specific antibiotics which there's most evidence are imipenem and meropenem. In terms of surgical management, this is indicated for severe complications, such as necrosis, pseudocysts, or abscesses. There are a number of different surgical options. These are laparotomy plus debridement, laparostomy, biliary tree compression, and finally ERCP and sphincterectomy. What's laparostomy, Johnny?
This is a procedure which is done if there's necrosis of the pancreas or the bowel. And you open the patient up, you drain all the necrosis, the inflammation, and then you cover the area with either mesh or a plastic bag, and then you leave it open and continue draining.
Okay.
And then eventually you go back to theatre and seal the patient up.
Yeah. Seal them up.
Seal them up.
Okay, so complications. Now, pancreatitis has lots and lots and lots of complications. And this is mainly because it's not simply a localized inflammation. It tends to be a more severe systemic reaction that occurs with this condition. And when you're thinking about it, think in terms of systems. So it most commonly actually affects the respiratory system. It can cause acute respiratory distress syndrome, lower lobe atelectasis, as well as pleural effusions. It can also affect the heart, leading to myocardial depression. It can affect the metabolic systems, as we've already said, causing a hypocalcemia, hypoglycemia because of a failure of endocrine function, and finally a metabolic acidosis. Hematologically, it can also cause disseminated intravascular coagulation. And if this happens, your patient's in pretty severe trouble. In terms of local complication, you can get necrosis, pseudocysts, abscesses, and of course infection. The most important of those localized complications are the development of a pancreatic pseudocyst, which is shown in this CT scan of the abdomen here. And this represents a collection of fluid within the lesser sac. It occurs in about 20% of cases of acute pancreatitis and should be suspected if there is a prolonged, permanently raised amylase. As we said earlier, pancreatic pseudocyst formation is an indication for surgery.
So, moving on to chronic pancreatitis. So, this is repeated episodes of pancreatic inflammation leading to structural damage and fibrosis. Once again, it results in exocrine dysfunction, so features of malabsorption, and endocrine dysfunction, such as diabetes.
Yeah.
Epidemiology. Unlike pancreatitis, this is uncommon, affecting about 30 per 100,000, and the main cause is alcohol.
What about some other causes?
Other causes are things like cystic fibrosis,
Yep.
congenital causes, so a pancreas divisum, which is when the unsnut process and the rest of the pancreas don't fuse in development. Other causes are hyperlipidemia and also idiopathic.
Yeah. But alcohol is definitely the most important.
So the clinical features, symptoms can be general, so weight loss or a poor appetite, or they can be specific, so the pain, similar to that of acute pancreatitis, exocrine dysfunction, so steatorrhea, or endocrine dysfunction, features of diabetes, so polydipsia, polyuria. Signs will be general signs such as being very thin due to malabsorption, and specific signs, so epigastric tenderness and erythema ab igne.
Yes, which is shown on this slide. And what's this caused by?
As it says, it's a hyperpigmentation of areas where people have put warm things, so hot water bottles.
Yeah, so often they'll put a hot water bottle on their tummy to get rid of the pain, and prolonged exposure to this causes this
Hyperpigment?
Yeah.
Yeah.
Awesome.
So, investigations. We went through the majority of them in the investigation of acute pancreatitis. So we went through all the blood tests, the amylase, the FBC, the lipase, etc. But extra tests that can be done for chronic pancreatitis. As we mentioned, the abdominal X-ray may show pancreatic calcification. The CT may show structural changes and more inflammation. And you can also do an MRI or an MRCP, which may show problem with the structure of the pancreas, so pancreas divisum, or indeed gallstones. There's also a functional test called the pancrealoral test. It's rarely used and only detects severe pancreatic insufficiency.
Yeah, but it's one of these tests for malabsorption, isn't it?
Yeah. So, management, starting with the conservative management, you need to control the pain, so strong opioid analgesia or a celiac plexus block. But it's important to note that these people are in chronic pain and may have problems with overuse of analgesia.
Yeah.
And indeed, they are also, the main cause is alcohol. So that issue may need to be addressed as well.
Yeah.
Okay, so surgical techniques that can be used are removal of any obstruction. This can be a stent or a cholecystectomy. You can drain the ducts or indeed any cysts using a pancreatogeginostomy. Or you can resect, such as a distal pancreectomy or a Whipple's procedure. And a Whipple's procedure is a proximal pancreatoduodenectomy.
Yeah. Okay, so finally, I'm going to talk a little bit about pancreatic tumours. As with all tumours, they can be benign or malignant. The benign ones are uncommon and often occur as part of the multiple endocrine neoplasia syndrome, or one of these syndromes. The malignant ones are more common. Most of them are ductal adenocarcinomas, and 85% occur in the head of the pancreas. Other tumours include the ampullary tumours, insulinomas, VIPomas, gastrinomas, and somatostatinomas. But these are really quite rare. In terms of epidemiology, the incidence of pancreatic cancer is increasing. It's more common in men, more common in the elderly, and occurs mostly in the Western world. In terms of risk factors, these can be divided into those due to lifestyle, disease states, toxin exposure, and congenital problems. So lifestyle risk factors will be smoking and alcohol. Toxin exposure, particularly within the dye industry, are exposure to naphthalene and benzidine. Disease states that can predispose include chronic pancreatitis and diabetes. As we've said previously, there's a condition called pancreas divisum, where there's failure of fusion of the dorsal and ventral embryonic buds of the pancreas, and this, as well as predisposing to chronic pancreatitis, also predisposes to malignancy. In terms of the clinical features, once again, we divide these into symptoms and signs. General symptoms include anorexia, malaise, weight loss, so typical stuff that you'd expect with a malignancy. Specific symptoms include chronic epigastric pain radiating to the back, symptoms of exocrine dysfunction such as steatorrhea, and symptoms of endocrine function such as diabetes with polyuria and polydipsia. In terms of the signs, patient may be very unwell with cachexia, signs of chronic alcohol misuse, perhaps liver disease. They may also have jaundice. In terms of specific symptoms, they may have a palpable gallbladder. And if you remember, when we spoke about gallstones, we talked about this law called Courvoisier's law. Courvoisier's law basically says that in the presence of jaundice, if you can feel a gallbladder, it's unlikely to be gallstones. And in fact, it's most likely to be malignancy. Other specific signs can be hepatosplenomegaly and ascites. This is often due to infiltration and liver failure. And two fairly interesting conditions, which are thrombophlebitis migrans and merantic endocarditis. Thrombophlebitis migrans is a phenomenon where you get multiple episodes of superficial phlebitis at different sites throughout the body. And merantic endocarditis is a rare form of non-infective endocarditis. In terms of investigations, once again, we go through our normal sieve. In terms of cultures, you want to do a urine dipstick, looking for the presence of bilirubin and glucose. In terms of the bloods, you probably want to do an FBC, which may show an anemia of chronic disease, Usinese, which may show a degree of renal function, liver function tests, looking for an obstructive jaundice pattern, clotting, because they're very sensitive at detecting abnormal liver function, perhaps glucose as well, if there's diabetes due to endocrine dysfunction, and tumour markers, specifically CA 19.9, which has a sensitivity of 90% for this condition. In terms of imaging, you may wish to perform an ultrasound scan of the abdomen that may show the mass itself, dilatation of ducts, and even the presence of gallstones. And you want to do a CT as well, a triple phase CT. And this is the best test. You can also, of course, use this for staging. MRCP may be useful to show structures around the pancreas. And finally, you might want to think about doing tests for metastases, such as chest X-ray, CT of the head, etc. In terms of scopic and biopsy, you might want to do an ERCP. which you can use to look for gallstones and to take biopsies. You can also do an ultrasound guided percutaneous biopsy as well. Functional, as we said before, there's this pancreoloral test, and this is basically just an advanced test for malabsorption. So here we have a CT scan showing a tumour in the head of the pancreas.
There's also probably an enlarged gallbladder here, would you say?
Yeah. And why would we have that?
Obstruction, basically.
Yeah. I mean, I'm not very good at reading CTs, but thankfully they've labelled stuff on here.
Yeah.
So management of these things. Management, of course, you need to involve an MDT, so you need to involve lots of different people, like oncologists,
Palliative, nurses.
Macmillan nurses.
Yeah, family.
Family. Very, yeah, that's important. Conservatively or palliatively, you can try and relieve obstructions with stents. You need to give analgesia. This is a very painful condition, so as with chronic pancreatitis, you need to give opioid analgesia or perhaps perform a celiac plexus block. And you can also give palliative radiotherapy. Surgery can be used, but only 20% of pancreatic tumours are found to be resectable. And the usual surgical technique used, as most tumours, 85% present in the head of the pancreas, is the Whipple's procedure, which is a proximal pancreaticoduodenectomy. Alternatively, you can do a distal pancreatectomy if the tumour is in the tail of the pancreas. And it's often thought that chemotherapy is useful post-operatively in these patients. However, as you might have gathered from the low surgical pickup rate here, the prognosis is really rather poor, with a mean survival of less than 6 months and a 5-year survival less than 2%. So, Patrick Swayze.
I loved him in all his films. What's that one where he's like that bodyguard of the bar? The Cooler. Have you ever seen
I
The
haven't
Cooler?
seen that.
Watch that film.
I like the classics.
He does kung fu and everything.
Like Ghost.
Yeah, but this one's a proper boys' film.
Okay. So, poor Patrick Swayze.
Yeah. He'll live on in our memories.
Forever. He's going to become a real ghost now. So, in summary, we've talked about pancreatic anatomy. We talked about pancreatitis, both acute and chronic pancreatitis. And finally, we talked about pancreatic carcinoma. So, thanks for listening. We've enjoyed recording the podcast, as always. So, it's goodbye from Ed.
And goodbye from Johnny.
Bye-bye.
Bye.